So, hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Italy, Professor Gianluigi Luigi Zona. Professor Zona is the chairman in the Department of Neurosurgery and Neurotraumatology at the IRCCS Hospital Policlinico San Martino, Genoa, Italy. His clinical interests are focused upon the management of brain tumors, pituitary tumors, cerebrovascular diseases, and mainly on traumatic brain injury. He is a noted author with several publications in various peer journals and book chapters, and we are extremely honored to have him today at our webinars. And today he'll be talking about decompressive craniectomy and reconstruction, which is cranioplasty, tips, tricks, and pitfalls. The speaker for the second session of today is our honorable guest from the USA, Dr. Laura Stone Maguire. Dr. Maguire is an assistant professor in the Department of Neurosurgery at the University of Wisconsin, USA. She is a fellowship trained in both cerebrovascular and endovascular neurosurgery from the University of Illinois. Her clinical practice is focused on treating patients with all types of cerebrovascular disorders and brain tumors. She has published more than 70 peer-reviewed articles and textbook chapters, and we are extremely honored to have her today at our webinars. And today she'll be talking about flow-based paradigms of vascular neurosurgery. The chair for the first session of today is our distinguished faculty from Brazil, Professor Wellington Paiva. Prof. Paiva is a professor of neurosurgery at the University of São Paulo, Brazil, and is a director of neurotrauma unit, Hospital das Clínicas de São Paulo. He is a research associate at the NIHR Neurotrauma Group at the University of Cambridge, United Kingdom. He was previously appointed as the departmental secretary of the Brazilian Society of Neurosurgery, and he has received around 19 awards in the field of neurosurgery, including the highest awards from the São Paulo Society of Neurosurgery twice and WFNS also. He serves as an ad hoc consultant for funding agencies, including the National Council for Scientific and Technological Development in the Ministry of Health, and he has published over 150 international scientific articles and 3 books, and has given over 100 lectures in 14 countries. We are extremely grateful to him for accepting our invitation to chair the session of Professor Luigi Zona. The chair for the second session of today's webinar is our honorable guest from the Czech Republic, Professor Jiří Fiedler. Dr. Fiedler is the chairman of Department of Neurosurgery at the Southern Bohemia Comprehensive Stroke Center. He is also affiliated to the Department of Neurosurgery at the University Hospital Brno Bohunice in the Masaryk University. His clinical interests are focused upon cerebrovascular surgery and skull-base surgery and ischemic stroke. He has experience of more than 2,000 carotid endarterectomies and over 300 ECIC bypasses. He has organized 12 biannual microvascular hands-on courses since 2000 and several cadaveric hands-on courses. He is a noted author with several publications in various peer journals, and we are extremely grateful to him for accepting our invitation to chair the session of Dr. Laura Maguire. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Prof. Wellington Paiva.
Hello, everyone. I think this is a great opportunity to discuss. This is a very interesting disease for us, neurosurgeons, and around the world. We start a first discussion about decompressive craniotomy and his relevance in our structure. About the decompressive craniotomy, his important historical aspects involving and about stroke. Malignant stroke and TBI. There is the 2 main indications for perform the decompressive craniotomy. It's malignant stroke and TBI. And there are more 100 surgical techniques in medical literature, and we need to standardize these conditions. We have several incisions and several ways to perform. It has impact the results of trials studying this kind. But one point important that we will be discussed today is about the volume, about the dimension of the decompressive craniotomy. With these patients at 27 years old, a victim of a traffic accident with 6 points in Glasgow Coma score, in another center was performed a small decompressive craniotomy with tragic evolution of these patients. Then the idea of the decompressive craniotomy is to perform a healed craniotomy, reduce the ICP monitoring. About the literature, we have 3 important trials studying this surgery for traumatic brain injury patients, and several trials studying this surgery in stroke. But for TBI, these three studies did not show improve in the quality of life, improving the outcomes of patients beyond life. In 2019, Professor Hutchinson from Cambridge was the director of consensus about the use of the compressive craniotomy in traumatic brain injury, with very important decisions about the management of these patients using this technique, using the ICP after the compressive craniotomy, about the technique that we must to do in this surgery. And there is an idea in my country and in several countries that, if you can help, then should always try this patient. But it's not true, because we have problems with this surgery. For this reason, we need to find the best patient to be submitted to this surgery, because we have early complications with hemorrhage progression, with hydrodynamics complications, and the late progressions with trephinate syndromes and other kind of syndromes. And after the surgery, we have another problem. It's about cranial reconstruction, about the cranioplasty. Then for stroke or for TBI, the evolution of these patients after some months, it's about several complications, and we need to do this craniotomy. And we think that the best option is early surgery, because in the late evolution, it's possible to have symptoms from trephinate and other syndromes from sinking skin flap syndrome. And in 2019, we took part of this important consensus. With leader was Professor Iacarino from Italy and Professor Severde from Italy as well. In the beautiful city of Naples, we discussed about the important questions in cranioplasty, about the indications and techniques to use in cranioplasty, about the materials, time, about the hydrocephalus after the compressive craniotomy, and the use in pediatric patients. And in this consensus, the main idea is the early cranioplasty, defined as within 6 weeks to 3 months after the compressive craniotomy, can do with small complications and possible to improve neurological outcomes. No single implants material it's superior. Then it's possible to use autologous bone or artificial devices, but it's not superior comparing to the two groups. And the hydrocephalus is an important concern in patients after the compressive craniotomy, and the use of the cranioplasty, it's possible to solve many of these problems. And you need the urgent need to have new trials, to have new studies to understand better about the cranioplasty and complications after compressive craniotomy. Our team has studied some aspects like time in cranioplasty, and it's interesting the possibility of the use of early. In our service, we prefer to do early cranioplasty compared with late cranioplasty. Then the Cuban's body of evidence gives us more doubts than certain about the use of the compressive craniotomy. But we think that in clinical practice, we believe that it's still a very useful technique. And today in this interesting webinar, we will try to discuss a little more about techniques and the strategy to define the best management of these patients. Now, after this introduction, we will have a lecture to discuss with deeper aspects of techniques and indications of the compressive craniotomy.
Thank you very much, everybody. I thank Professor Paiva for this kind of introduction, and I agree with him that we have a very powerful tool, but actually we don't know which are the best patients we can offer this powerful tool. A brief history of the comprehensive craniectomy should emphasize the role of the fourth edition Brain Foundation recommendation that were published in 2016, just a few months before the publication by Peter Hutchinson about the rescue ICP. And actually, if we see at the recommendation in 2016, the bifrontal decompressive craniotomy was considered not superior to standard medical management in the outcome of patients. And many people at that time believed that this kind of procedure should be abandoned because not superior was not demonstrated. Actually, in 2020, there was a supplementary recommendation after the publication by Peter Hutchinson that stated clearly that the comprehensive craniotomy low intracranial pressure and that must be performed according to clear surgical techniques. As you show, the blooming brain is one of the main problems in this kind of surgery. So we know very well by many evidence in literature that the comprehensive cranectomy lower intracranial pressure, especially, and it had to be associated with the neuroplasty because otherwise it does not make any sense. I'm speaking to younger audience. And at the same time, it is very well highlighted the importance of temporal bone craniectomy to free the basal cistern that improve the outcome of our patients. So there are some milestones that has to be very clear in mind of younger people. Not only it lower the intracranial pressure, but it improves also cerebral metabolism, as has been shown in several articles. Generally, intracranial hypertension and PtO2 are inversely proportionate after opening of the cranial vault and of the dural matter. This is a very young Peter Hutchinson, just few months after the publication of his article, and he clearly demonstrated that there's an advantage for people in late refractory intracranial hypertension. That was the main difference with the DECRA study that was published in 2016, in 2019 by Cooper, that we have a lower mortality in patients that underwent to cranial decompression, but with an increase on vegetative state. So it is very important that we should reserve this kind of surgery to a selected population of patients, but actually we are not completely able to identify these patients. But are the DECRA study and the rescue ICP study completely different? I had a long discussion with Corrado Iaccarino, Nino Stocchetti, and the Italian group of traumatology, because if we compare the results of the DECRA study and the rescue ICP study, it depends what we consider a good outcome or a bad outcome. Because if we consider lower disability and we change our statistical result, we see that in the first case, in the original DECA study, there was a significant result about not superiority of the compressive craniectomy. But if we change, according to Peter Hutchinson, this chi-square test is not significant anymore. So the definition of what we consider as dependent or independent people, it's very important to have any consideration about this. The comprehensive cranectomy, as shown Professor Paiva, is used in TBI, in ICI, in subdural hemorrhage, in stroke, in tumors. So there are many pathologies many cases that in neurosurgery we can use the comprehensive craniectomy, but we have to consider as a continuum the comprehensive craniectomy and the reconstruction. And complication can occur either related to the bone removal surgery, either to reconstructive surgery. It is wrongly considered as a trivial surgery because it's not very demanding, but is a surgery that can have very high complication. So that has to be performed according to strict criteria to have the best results, because it is well known that the high mortality and morbidity of this surgery can be very harmful for our patients. All the history starts with the bone removal with an increase in brain compliance and improvement of CBF and autoregulation. Then alteration of CSF dynamics leads to complication in our surgery. Let's start. Okay, no, sorry. Okay. With timing of appearance of this complication, we should divide it in perioperative complication and post-operative complication, I mean, within 30 days from surgery, and delayed complication, I mean, after 30 days after surgery. And the main perioperative complication are blossoming of contusions, epidural hematoma, external cerebral herniation, intracranial infection, maybe epilepsy, CSF leakage, and wound problems. During bone decompression, there could be the development of new expanded contusion and malignant swelling, leading to these horrible pictures of CT scan after surgery, as well as epidural hematoma in the site of surgery. Hypoperfusion may lead to brain swelling and the loss of resistance to displacement of brain tissue through the bone defects, causing the so-called fungus cerebri. I mean, so fungus cerebri is not a complication. Fungus cerebri is the result of a wrong operation. It's completely different. We know that suboptimal craniotomy can lead to these pictures, but this is, in my opinion, is not a complication. It's a wrong surgery that has been performed with a too small craniotomy during the night or by our younger collaborators. That's why one of the statements of Brain Trauma Foundation is that craniotomy has to be as large as possible. That has to be with a wide frontotemporal bone flap, at least 15 per 15 centimeters, toward the middle cranial fossa to free the basal sisters, and of course, it has to be associated with an expansive duroplasty. That's a statement. There's no discussion about this. Postoperative complications that develop within 30 days from surgery are mainly subdural effusion of hygromas, evolution of contralateral mass lesions, paradoxical herniation, and infection. Subdural effusions can be beneath the defect, bilateral, or contralateral to the defect, and are mainly related to the alteration in CSF dynamics. Evolution of contralateral mass lesion, but always should rule out with the serial CT scans. And this is the so-called paradoxical herniation that are often seen after, for example, after lumbar puncture for the suspicion of infection or other possible disease. Infections is a main chapter that I see Professor Paiva saying yes, because infection can interfere very highly with the reconstruction. I think that actually decompressive craniectomy, cranioplasty is the same intervention in 2 stages, because we always have to think to reconstruct when we perform a decompression. So it's not a difficult surgery, but it's a heavy decision to take. After 30 days, the two main syndromes are the so-called syndrome of the sinking skin flap and the trephinite syndrome and hydrocephalus. The syndrome of the silky skin flap is due mainly to the action of the atmospheric pressure on the defect that deforms the brain parenchyma and can produce neurological deficits. As well as Professor Paiva already said, in 1939, the so-called trephinite syndrome, that is a syndrome encountering different neurological symptoms, has been described in 1939, and the the expression of an alteration of compliance of brain parenchyma due to different factors such as dynamics, venous flow impairment, cerebral contusion, that finally decrease the perfusion of the brain parenchyma that is stored actually after cranioplasty, and that improve clinical symptoms after cranioplasty is performed. This is a personal case. The other main problem is hydrocephalus. Hydrocephalus, as we discussed it in Naples, as say Professor Paiva, has been the matter of a consensus in the European Association, led by Franco Servadei and Corrado Iaccarino, one of my two best friends in Italy. And actually, can we avoid the development, or we lower the incidence of post-decompressive hydrocephalus? Pasquale De Bonis and Carmelo Anile many times ago demonstrated that the quality of craniotomy can interfere with the development of the hydrocephalus. And for younger people, the message is don't to stay too close to the midline during craniotomy because it can increase the risk of developing post-decompressive hydrocephalus. In fact, the only parameters that was significant in their study was the distance between the midline. If we perform a decompressive craniectomy in a distance lower than 25 millimeters, 2 centimeters and a half, the higher is the probability of developing a post-decompressive hydrocephalus. Okay, that's the result. That's why last year we published with Corrado, Franco, and myself a consensus dealing mainly, and I show you where the appropriate Delphi consensus about post-decompressive hydrocephalus, and the main result where all people agreed with and was considered appropriate the statement is that in present hydrocephalus, cranioplasty must be staged. So that means that cranioplasty has been to be performed before, and then after we have to demonstrate, and it is not always easy, if our patients need a definitive ventriculoperitoneal shunt. That test can be performed during surgery if there's swelling of the brain parenchyma through the bone defect, and ventriculoperitoneal shunt is preferred to lumboperitoneal shunt, as well as the use of adjustable pressure valve before rather than fixed pressure work valve. So to spare time and to have much more discussion, the tips and tricks that we can suggest to younger people is that the larger myocutaneous skull flap are needed to preserve the temporal superficial artery because of it can decrease the risk of infection of the wound site. Large craniotomy, duroplasty is pivotal. Bandaging of the skull in case of edema, and CT scan are always to be performed when there are contralateral fracture or contusion to rule out the development of epidural hematomas or enlargement of contusions. And now let's go to the second part of the same operation, that means the reconstruction. We need to reconstruct these patients. And is it a problem? Yes, because a lot of complications occur actually during the bone replacement. 34% of patients that underwent cranioplasty experience at least one complication. That is a very high number in our daily practice, because a reoperation rate of almost 20% and the complication rate of 33% is very, very high in all over the type of surgeries. Timing is a very, very debated matter, as Professor Paiva said. Actually, we don't have a precise number which is the best material to reconstruct the scalp. And I actually believe, according to many of my colleagues and friends, that it is better to perform reconstruction as soon as possible, but it is not, but it is mainly related to the complication. So if our patients are not infected, if the wound is good and the edema is resolved, it's better to reconstruct as soon as possible, because the best period is generally considered before 3 months, as we will see later. The two main parameters that were studied by Corrado Iaccarino was according to the possibility of developing complication is the material used and the preoperative scan. There are many articles about the best timing to perform cranioplasty. And as we can see, there are many articles that see no difference. Many that see the early reconstruction is better than late reconstruction, as well as many articles say that the early is worse than late. If we plot all these results, we can see that we are not sure about when to perform, but probably the best period is in the first 2 months after decompression, because the higher incidence, if we plot all the complication, develops generally between the 3rd and the 5th month after decompression. So if we are able to reconstruct our patients in this period, is probably the best period, but it depends actually by the condition of our patients. As our Pakistan colleagues say, there's no a magic number, but it depends by the condition of the patients, that's for sure. So the message for younger people is reconstruct as soon as possible, but when the condition of the patients are sufficient well to be reconstructed and to avoid the infectious complication. This is the plotting I said before. And what about materials? We can spend many time about materials, and we should probably need many hours to discuss about materials, because there's no material that has been proved to be superior one to another. Autologous versus heterologous biomaterials, biological reconstruction or healing, that's a philosophy that we have to bear in mind. I mean, if osseointegration cranioplasty is or is not a false problem. I think that we can discuss a lot. I think that osteoconductive materials are to be preferred, but they are more expensive than the other one, and sometimes are more fragile. So every material has some advantages and some disadvantages. So we have to find a middle way between the reconstructive medicine and the regenerative medicine. And it is almost the same problem as for reconstructive medicine is to close the door or to lock the door. It's completely different. Probably to close the door is good, but it's best if we can lock the door. So I thank you very much, Corrado Iaccarino and Roberto Stefini, and Andres Robiano is not here, but we share a very good moment together here in Genoa some months ago. Thank you very much for your invitation, and if we will discuss, I'm very happy to do it.
Congrats, Professor Zona, for your comprehensive revision and discussion about this very important topic for our patients, for us. And we want to start this discussion with some points. The first one question or one point for discussion. What your opinion about range craniotomy and the use in the practical parts? Do you think that it's useful? There is a special case for expensive craniotomy with range craniotomy, or it's not possible to do it?
I did not hear very well the question about the hinge craniotomy.
Yes. About the range craniotomy.
I actually believe that hinge craniotomy, and we are starting a multi-center study, prospective here in Italy, could be a very good option to cranioplasty. I actually believe that it is a very good option, especially in low-income countries that cannot afford for biomaterials. Not only for this, but also because with hinge craniotomy, probably we will lower the complication rate of this operation. So I am quite well positioned about hinge craniotomy. Actually, we do not perform hinge craniotomy, but I think that it will be a good possibilities, alternative possibility.
And one point it's is about the ICP monitoring after the compressive craniotomy. Do you think that is important? What do you think about this kind of management of using ICP monitoring?
We discuss a lot about this. I think that after you mean after the compressive cranectomy, ICP monitoring?
Yes, after, not before.
After. I think that we need it. We need it because we have to help our intensivists to guide treatment. So ICP monitoring is anyway is not a number, as I say always, because ICP monitoring is a matter of different, the quality of the curve. We can speak a lot about this, but I think that if I perform an operation that lower the ICP, I have to demonstrate that the ICP is lower, and I have to manage it by medical strategies after decompression. So I think that the ICP monitoring after the compressive craniectomy is useful.
And I want to hear from guys from Asia. Dr. Haja, do you think that it's possible to use, do you use ICP monitoring after the compressive craniotomy? It's how the vision from Asia about this topic?
Well, I work in a public sector department, so we do not have an ICP monitor, but we generally go with clinical findings and based upon our interventions depending on the clinical findings rather than ICP monitor. But just because we do not have it, that is the issue. What about Ben? I think Ben would be a better person. He's in Hong Kong. Ben, what do you think? Do you have an ICP monitor in your place?
Yes, we would monitor the ICP even after decompressive craniotomy. So in terms of external ventricular drain. So and I know that I would like to ask about in a few years ago there is still advocates about measuring the RX and also the PX and then to optimize the CPP and the ICP. So what is the current opinion towards that? And my second question is about
well, we'll come to questions later. Just finish this off about ICP. We can hear from Liu also. What about Liu? Is from Malaysia. He's a better person to answer.
I think the main idea after the compressive cranectomy is to drain the CSF, and where this EVD can be utilized for both draining the CSF. I believe that the CSF production will not cease after our decompressive cranectomy, and it helps. But generally in our place, the best guide for intracranial pressure is using your little finger on the decompressive side. If you get a hard surface, means intracranial pressure are very high. So usually, sometimes the clinical will tell us. But again, many people say the ICP may not be accurate after you convert a closed box to an open box. But again, like what Prof had mentioned, it's not the numbers, it's the changes that matters to us. And also, when do we need to do a repeat scan? Because like have shown many cases that contralateral problem. One of the key aspect that we can observe beside looking at the pupil is looking at the ICP. The changes of ICP may guide us when do we need to have a repeat scan, because a frequent transfer patient out from the ICU for CT scan also another hazard for the patient, I think. Yes.
That's it, Prof. Paiva. You heard it from the Asian counterparts. Go ahead, please.
And about the other question is about the best incision. With the kind of incision, Dr. Zona, do you use in our service? It's a T incision or a question mark? What your
question mark incision? Question mark
incision. Yes.
Yes. Bilateral frontal decompression is very rare. It's very rare in my experience. We generally perform a monolateral decompression by question mark. We don't stay too close to the midline.
Yeah. But do you have a problem about the ischemic incision in the posterior part?
Yes. That's a problem. That's why I teach my younger collaborators to preserve superficial temporal artery to decrease the risk of necrosis of the posterior part of the skin incision. But of course, the other possibilities you showed is the T incision that theoretically have less chance to have skin ischemia, but we generally perform a question mark. And about post-decompressive ICP monitoring, I agree with our Malaysian friend that is not an absolute number, but is a relative number that can detect complication before CT scan. And we are now studying the use of, with Chiara Roba, the use of pupillometry to replace intracranial ICP monitoring. I think that is, it could be, we are not completely aware of the exact correspondence between ICP monitoring and pupillometry, but pupillometry is generally altered and the reactive time is altered in case of intracranial pressure over 25-30 millimeters of ACG.
And about the cranial reconstruction, the cranioplasty, how do you manage the temporal muscles? You put the muscles, you consider the muscle is possible to close to the dura. It's need to dissection the temporal muscles during the cranioplasty. What your idea about the technique in the management of temporal muscle after in the cranioplasty?
Attachment of the muscle to the dura reconstruction or the dura substitute could be very difficult to dissect during reoperation. Very, very difficult to dissect. In Italy, we are trying to check for the use of some inert materials to put between the muscle and the dura mater to have a clear plane of cleavage when we have to reoperate. Is a silicone film that is very useful because the muscles do not attach to the dura and the operation time and bleeding loss is much less with these possibilities because it is actually a problem. Yes.
And about dura.
If I may add to that, Prof. Zona, what you said is rightly true. I have published the first study regarding what happens when you take off the temporalis muscle and put it back over the bone or when you put it back with or without temporalis dissection. And this is the first of a kind of study that we have done, ever published, and we looked upon what is the bite force, influence of bite force on either when you dissect and keep it over the bone or just keep the bone over it. And we found that it is like both techniques improve bite force, but a trend was towards when you dissect and keep the temporalis muscle over the bone. And as you rightly said about the silicone film, we use a double layer of a prosthetic G-patch material. So it is easier for us to dissect the temporalis of the dura.
Let's hear from other guys in the panel about the temporal sections in Hong Kong and other countries in Asia. What the idea about the temporal section during the cranioplasty?
You?
Yeah. I think the duration when we perform the cranioplasty will tell us. Usually we try to do not beyond 1 year. We have a freezer to keep the bone, or not. Sometimes bone resorption may be a problem. But I think the best key is intraoperatively. If you try to bust the muscle, if the muscle doesn't contract, there's no role to separate it. If the muscle is still functioning, then we should try our best to separate it. More importantly, is a person who did the decompressive craniectomy. There are also some trend that people do not put a duroplasty at the temporal region. Mean they just flap over the temporalis muscle during the closure. This is a difficult case when you try to dissect because there's no plane at all. So you need to really know that the person who did the first surgery, whether there's a duroplasty performed or not. If not, then should not attempt, because CSF leak is the biggest problem in cranioplasty, I think. Then we should not let that happen. Thank you.
I agree with you. It is very important to know the technique of the first operation, because sometimes we receive patients from abroad, for example, and we don't know. Lastly, we received the patients from that was on holidays in Martinique and was decompressed of a malignant ACM stroke, and they put the bone flap, the autologous bone flap, in the abdominal fat. It is not allowed in our common law, so we had to perform an heterologous with peak cranioplasty. But it is very important to do what the first surgeon did, because it is very important, because otherwise you get problems during the second operation. Yes.
How about Ben?
Yeah, for me, of course, it's important to look at the first surgery, and for us, the time for the cranioplasty is variable because it depends on the availability of the operative slot. So it really depends, but we know that the early cranioplasty would probably benefit the neurological outcome. So for the dissection of the temporalis, we would try to, or I would try to find the correct coverage plane between the temporalis and the dura, if possible,
Right.
and then to attach it to the bone fat. Yeah, that's what I would do.
Yes, we have Hui from Vietnam, another high volume center. What about you, Hui?
Hello everyone. My name is Huy from Hanoi, Vietnam, and in here we do a lot of cranioplasty, especially for the patient following decompressive craniectomy for traumatic brain injury, because we have so much traffic accident here, and on most cases we try to dissect the temporalis muscle off from the dura and place over the bone flap. It's much easier when we do the cranioplasty early, maybe within 1 month from decompressive craniectomy if possible. During the first surgery, we don't really have the film, as you mentioned, but we place some gel foam between the dura and the temporalis muscle that could help us to dissect the muscle more efficiently in the cranioplasty.
Thank you, Liu.
And another important question is about hydrocephalus in patients after the compressive craniotomy. With the best management for the hydrocephalus. It's we need to only to do cranioplasty plus EVG, ventriculoperitoneal shunt before cranioplasty, after cranioplasty. What the best management of patient with hydrocephalus before cranioplasty, after the compressive craniotomy.
We studied the problem because actually we have no definitive answer to this problem. But some points are clear. To never perform a ventriculoperitoneal shunt before cranioplasty. That's for sure the only thing to avoid. If you have to manage, it's better an external drainage to put cranioplasty and to look if the patients still need a ventriculoperitoneal shunt, but never put a ventriculoperitoneal shunt before cranioplasty. And after cranioplasty, if the patient need a ventriculoperitoneal shunt, and we could discuss which are the best diagnostic criteria to do this, TAP test or cognitive test in the long time, because this kind of hydrocephalus in the long time is quite similar to normal pressure hydrocephalus. It could be associated with normal pressure hydrocephalus. Sometimes we see patients that improves during rehabilitation, but they became to a plateau and do not improve anymore. And after the valve, they improve anyway, again. So I think that we have to think about if we need to put a valve, we have to put a valve because can improve the outcome of our patients. And if you put a valve, we have to put a programmable valve, exactly as for idiopathic normal pressure hydrocephalus. Very similar.
And in other countries, how the management of hydrocephalus after the compressive craniotomy?
Well, the question is very difficult. I would rather differ from Prof. Zona, because in our places we have patients who are generally lost on follow-up. Okay, so they come with acute deterioration and we have no other choice than to put in a shunt for acute hydrocephalus. So that is one of the main issues we have in our place. And also regarding what you said about this when to do, whether when to do, what to do is also another question. We generally put in a medium pressure valve, but it's a fixed pressure valve, as we are not having this facility of a programmable valve. Of course, programmable may be better, I do not know. But regarding what the consensus is, because whether you have to evaluate with it when it is actually hydrocephalus, because the ventricular dilatations can occur due to atrophy, can occur in normal pressure hydrocephalus, can occur due to high pressure hydrocephalus following TBI. So which is what we do not know. So what we did in, I published my study about the conundrum of ventricular dilatation following decompressive craniectomy in 2017. We had a small series, and during the cranioplasty, we put in a ventricular catheter and measure the ICP. If the ICP is high, we would invariably put in a shunt. If it is marginal and the ventricular are dilated, we simply aspirate 20 to 40 ml of CSF, and when the brain shrinks, we put the bone flap back. Sometimes we do retain this EVD as a catheter for a week and then remove it. Otherwise, if the brain is sufficiently lax, we would, if the patient is also asymptomatic, we would remove it there itself in the theater. So that is about a very difficult question, as you said, and also there are several published articles where you stage the surgery or do it in the same setting, and during the same setting the complications have been plenty rather than when you do it in a stage fashion. So that is what my experience. I would love to hear from Liu, Ben and Hui. Liu?
Yeah, in my center, I did perform both together, cranioplasty and shunt together in some cases. What important, I think my observation is those with obstructive hydrocephalus, I think the chance the hydrocephalus to resolve by itself spontaneously after cranioplasty is very unlikely. So in those cases, usually I will prepare shunt and simply, also because I want a balance of pressure, because once you put back the bone, you cannot allow any increment in pressure, which is very dangerous for the patient. At the same time, you cannot drain the CSF, and hopefully there's no subdural space after the cranioplasty. So usually we do that, but in cases communicating hydrocephalus is safer to put back the bone without a shunt, especially those when there is a unilateral dilatation on the ipsilateral side, those that you can tap just to enough for you to put back the bone. I think those are safe. However, we do need to have serious scan within a week to make sure that everything is going fine. Because once you send the patient home, then disaster happen, then it's too late for you to do any intervention after that. So that is our practice in Malaysia.
I think it's very important what we mean for hydrocephalus, as you said, because if it's homolateral to the cranial defects, mainly it is not an hydrocephalus, but it is an enlargement, a benign enlargement, so-called benign enlargement. So you just have to puncture the ventricle to put the cranioplasty, and that's all. It's completely different if the dilatation is bilateral. But I think that the message is not to put a valve, because in our study, we prefer a stage operation, but not to put a valve before cranioplasty, because the sinking flap syndrome is very, very dangerous for our patients. So we can perform at the same stage, we can perform the BP shunt after cranioplasty, but never before.
What about Ben?
Yes, for us, most of the case would be we usually perform a staged surgery, so usually cranioplasty first, and to observe the trend of the ventricular size. So sometimes after surgery, we might if the ventricle really bumps up and the patient has still have a poor quality function of poor GS, we might consider to have a diagnostic lumbar tap to see if the conscious improve after the cranioplasty. Yeah, to decide whether we proceed to the shunt.
How about Hui?
In my center, it depends a lot on the extent of intracranial pressure that we can evaluate clinically by examining the skin flap at the craniectomy side. If it is sunken skin flap, of course we don't do VB shunt or any type of shunt for that case. But for the really significant pressure at the skin flap, we place that at the same stage. But for the medium pressure, we can do the cranioplasty first, and then we can place the lumbar drain and try to evaluate if the patient is really need the VB shunt later.
Thanks, Hui. Papaiva?
Yeah. In my service, we manage these patients with the temperature. They try to do a cranioplasty for the mild or moderate hydrocephalus. And for severe hydrocephalus, we try to use EVG with cranioplasty in the same procedure, and decide in the following days if the patient will need ventriculoperitoneal shunt after the cranioplasty.
Yeah, I want to just add a point that for the shunt itself, we usually use the variable variable shunt that
Programmable, you mean programmable?
Yeah, the programmable shunt that we can adjust. Yes, I would also like to hear from Yusuf from the expert panel. So I think after the cranioplasty, maybe the compliance of the ventricle might change, so that if you put a fixed pressure valve, and then it might not be you might have a variable degree of subdural collections, and then at different stage of time. So what's your opinion? Yeah.
Upsana? Professor Zona would like to answer that.
Question, not an answer. Higher question. Have you any tricks to reduce the percentage of resorption of autologous bone? Because it's a problem. It's less expensive than biomaterials, of course, but in some series, there's till 30% of resorption of this kind of bone, because actually its behavior as an external material that is almost, should say, rejected. So have you surgical tricks to reduce this complication that needs another operation, of course?
If I may add to that, the problem with that question is that criteria were never defined. If you go through the literature, there are like several criteria ranging from mild thickness of absorption to a gross shrinkage in size, and so there are different criteria for. I think the most comprehensive definition was the Oulu resorption bone resorption score from, I think, Finland, and it is very cumbersome. It is like some 6 or 7 criteria. So the definition is variable in the literature. That's why the incidence is also variable. Well, I can only say from my experience that we have, because we do not have a refrigerator, the ideal recommendation is minus 70 degrees Celsius to store the bone flap, which is very difficult in a low, like public sector that I work. We always keep it in the abdomen, and we have seen variable rates of absorption, but we always augment the edges, and if there is a large defect, always we put in a mesh, the titanium mesh, which we always have a stock with us. So that is the problem with the question you asked, Prof. I would love to hear about others also. Yes, Liu?
We do have a problem. Initially, I thought it's only happened in elderly, but it's also sometimes happen resorption in young patient, fresh bone. And we try both, put in the fridge and subcutaneously. Both also experience the same problem. They get reabsorbed anyhow. The worst case scenario is after cranioplasty, the resorption happened. Then it became a sunken flap with the bone there. I think it'll be a bigger problem than without a bone. I think that I do not know what's the real cause of it, because it happened in so many factors being involved. But I think the point is, I think probably in my setup, the cranioplasty was not performed early. I think the early cranioplasty may be the key to allow reduce risk of resorption. I think probably another important thing where we always do in neurosurgery, we always bust cauterize the dura surface to make sure no blood supply, bloodless, to avoid any extradural, epidural collection. I think probably we doesn't really need to do so, because I believe that the blood supply from the dura may help to actually supply the blood to the bone and reduce the risk of reabsorption. That's just my opinion. Thank you.
Hui or Ben?
Yeah, I think it's highly unpredictable for the absorption. So I don't know, some patient to absorb, and then for some patient after many years the bone flap is still here. So I don't have a good answer to that, but this observation is highly predictable. I don't know which one would resolve and which one would not resolve.
About Hui?
We are actually doing a case control study at the moment, and we expect to publish the paper in before it's mean maybe in October or November. And we have around 50 cases of bone resorption and 100 cases of control. And we found at the preliminary results, we found 2 factors that are associated with bone resorption. That is hepatitis, either B or C, and also the advanced age as well. So advanced age might be related to the bone healing, and hepatitis might be related to the immune mechanism. So they are our early result on that. So maybe I can share more when we do the full analysis later.
That's great, Hui. Prof. Paiva?
We are almost finished our time to discuss this topic, but I have the last question. It's impossible to discuss with a great professor from Asia and not to talk about cysternotomy. What the space for cysternotomy versus the compressive craniotomy in GBI. In Latin America, we don't have a great experience with this technique. We are waiting for the more evidence, but it's an interesting option from Asia. And I want to hear from the professors of this panel their opinion about this technique for patients with intracranial hypertension from GBI.
Prof. Jonah?
Yes, we discussed a lot in Europe about the techniques of hyperchirion. That I think it makes sense. But after the publication of Peter Hutchinson, we should never be allowed to have a randomized control trial. I mean, for patients in intracranial hypertension, we do not offer decompressive craniectomy. So we can only add cysternotomy to decompressive craniectomy. But in this case, it would be very, very difficult to, we could have a study about outcome, not about lowering the pressure, because we don't know if it is the compressive craniectomy or the cysternotomy. So I think that actually it will be very difficult to have an RCT trial, a randomized control trial in Europe after the publication.
Okay. Prof. Paiva?
Always be asked to have decompressive craniectomy in all, how to say, ethical committee to be approved such a study.
Okay. We can conclude, Prof. Paiva?
Then it was a great experience, a great discussion with important professors from all parts in the world. We think that it's a very important topic for the surgery, for the patients, especially in countries with low to middle income and I believe that was important, especially for young neurosurgeons. And now we with the next topic
Yes, we'll take over. Thank you. Thank you very much. So it was indeed a very wonderful session, and we really it turned into a discussion type, but we really enjoyed it and learned a lot of new things from you both. Thanks to Prof. Jonah and Prof. Paiva for taking out your time for the ACNS webinars. I would like to mention our viewers that we are broadcasting on WeChat, YouTube, and Zoom. And thanks to Professor Shubin, we have around 1,130 people who are live now for this webinar on all the 3 different channels. So thank you very much. So I'll hand this podium over to our Honorable Chair, Prof. Jiri Fiedler, to take over the second session.
Dear colleagues, it's honor for me to introduce the second topic of today's session. Dr. Laura Stone McGuire from Department of Neurological Surgery, University of Wisconsin, is going to talk about. The flow through a tube depends on a pressure gradient, properties of liquid, and the resistance of the vessel. These days, we are able to determine vessel's flow volume, flow characteristics in particular areas of the vessel with high precision, both during surgery and outside the operating room. It's important, however, not to confuse between flow volume, velocity, and patency. In cerebrovascular surgery, we make decisions based on the knowledge of the flow volume in manifold of Willis. This field was established at UIC Chicago and is synonymous with names Faditi Charbel and Sepideh Amihanjani. Dr. McGuire completed her residency at the UIC Chicago program, and she also completed a double fellowship in neuroendovascular and open cerebrovascular microsurgery with Professor Charbel. Professor Charbel praises her very highly and says that she's excellent. Finally, the list of 70 publications of Dr. McGuire is outstanding and concerns both open and endovascular treatment of a whole spectrum of modern cerebral vascular surgery, including carotid operative. Please welcome Dr. Laura McGuire.
Thank you so much for the introduction. That was very kind, and it's such an honor to be on this webinar and to be with this esteemed group of neurosurgeons. So I will share my screen so you can see my PowerPoint. So I will be sharing with you a lot of the thought process behind flow that I learned at the University of Illinois at Chicago in my training that was referenced. But this is the flow-based paradigm of vascular neurosurgery, and I hope that this will at least start to get you thinking about how we think about flow in different cerebrovascular diseases and how we can apply some of these different imaging modalities to better understand flow in these diseases. I'm currently at the University of Wisconsin, where I've started as an assistant professor there. So my outline today, it will mostly focus on bypass surgery, but some of these imaging techniques can be used for a whole host of diseases in cerebrovascular neurosurgery. So I will focus the majority of the talk on bypasses, but I do have a few slides at the very end to show how we can use it in other diseases also. But first, before I get too far ahead of myself, I do have these photographs of all of my mentors at the University of Illinois Chicago, Dr. Charbel, Dr. Alaraj, Dr. Otwal, Dr. Hanjani. All of them were very crucial in my training, of course, and in bringing this type of thought process to neurosurgery. And then a lot of the research that I'll present, some of it is research that I've been involved in, but some of it is it predated my experience, and it was really the foundational work that was done at UIC. So it's a mix of work from myself with them, but also with them and other collaborators. But in this presentation, I'll talk about bypass, I'll talk about patient selection, I'll talk about intraoperative measurements too with the microflow probe. I'll talk a little bit about why we think bypasses might fail, and then some final words. So first off, why perform a bypass? In general, there are two categories that we like to think about. There's flow augmentation and flow replacement. Flow augmentation aims to restore flow to hypoperfused brain territories in patients with steno-occlusive diseases. Flow replacement, on the other hand, aims to replace the blood flow provided by major intracranial vessels, the occlusion of which is necessary to treat an underlying disease, such as an aneurysm or a tumor. But the focus of the next few slides will be on this flow augmentation. However, the principles do also apply for the other types of bypasses as well. So in flow augmentation, this is something that has been critically studied in a few randomized clinical trials. So we have the ECIC bypass study group that was in 1985. We have COST study in 2011. We have Japan adult Moya trial in 2014. And we have the more recent MCOS in 2023. And in these different studies, this gives us insight into who is and who is not a candidate for bypass. And I'll get to that in my next slide because this is important because some of these diseases have clear recommendations and some do not. So in Moya disease, in America, we have the American Heart Association and American Stroke Association recommendations that are Class 2A for recommending surgical revascularization for those with symptomatic Moya disease. And this is mostly supported by the Japan adult Moya trial that I mentioned. Which was specifically for hemorrhagic Moya disease, and it found a reduction in rebleeding risk in those patients that underwent direct bypasses. But no prospective RCTs have been performed to address ischemic moyamoya disease. But there have been several meta-analyses that generally support surgical revascularization in this condition. So in general, for moyamoya disease, it's relatively straightforward that you can perform bypass surgery with good clinical outcome. And I must apologize, there's going to be thunder in the background here. It's a storm outside, so I don't know if you heard that or saw the lightning strike, but outside the window it's quite loud. All right, for intracranial atherosclerotic disease, this is less clear, as I mentioned, and that's due to the failure of those 3 trials to show a benefit. The IC study, COS, and CMOS, all 3 of them did not show clear benefit for performing a bypass. But CMOS did acknowledge that their study was underpowered due to a lower expected event rate in both of the groups. So that is a caveat for their particular study. But is there still room for bypass in select patients? And I think that there is. And a possible approach, might be considering this occlusive disease, might be considering hemodynamic reserve, failed medical management, progressive and crescendo symptoms, but really this emphasis on impaired and worsening hemodynamic reserve. And the question is, how do we measure that? How do we assess that? And that is something that we looked at extensively at UIC. So it comes down to how do we image cerebral blood flow first. Now, this technique with quantitative MRA, specifically with NOVA, this was developed at UIC. And NOVA uses 2 different types of MRI sequences. You use time of flight to provide the high-resolution vascular anatomy, and that allows you to actually select for the vessels of interest that you then want to come back and perform the phase contrast technique, which measures the vessel velocities and the cross-sectional areas. That allows you to estimate flow, so you get the milliliters per minute through specified vessels. There's one limitation with this technique, though, that I think is a pertinent one, is that you really have to rely on your staff to do a good job with this, because you cannot perform post hoc measurements. So you do have to know what vessels you want and have good approximations of your vessel of interest right when the images are acquired, because you cannot go back and redo it unless you actually bring the patient back for a repeat picture. Now, there's a different technique this is something that I am working with at University of Wisconsin. This is 4D flow with PC Viper. This is a time-resolved phase contrast MRI, and it does have 3-directional velocity encoding with really good spatial resolution, 0.6 to 1 millimeter. And the images can be acquired in all planes within a single session and processed after acquisition. So that is a nice advantage to this particular technique. But it's not as well studied for the diseases that I'll be talking about. So actually, from this moment on, most of the studies that I'll be talking about are still using the NOVA technique. There is a paper that was published several years ago that did highlight the normal cerebral blood flow ranges. And so this has been standardized and then replicated. But this is a table that summarizes these, and this is going to be the study that this comes from. So what do you expect for these blood vessel ranges? And it does change with time. As individuals get older, blood flow in all vessels does decrease with time, but you still have a good sense of what normal ranges should look like. And so then anything outside of that would raise a flag that something might be going on. But this blood flow assessment's not enough, especially with the diseases that I was talking about, with intracranial atherosclerotic disease, with moyamoya disease. You really want to get a sense of what the reserve is, what the capacity of the brain is to handle any kind of problems with blood flow. So normal cerebrovascular reactivity response to vasoactive stimuli like carbon dioxide becomes impaired in steno-occlusive disease. So that's known. Cerebral autoregulation also becomes dysfunctional. You can no longer provide adequate blood delivery to the brain. And because this process is based on regional metabolic demand, independent of systemic pressures, regional assessment of reserve is also important. And so I'll talk about that a little bit with some of the technique that we use, so that it gives you not only this global assessment, but a regional assessment too. Vessels distal to the stenotic artery can become habitually dilated as a compensation to preserve blood supply. And so this is where the challenge becomes important. You add a vasodilatory challenge to assess the response of the arteries that are distal to the stenosis. And in the most severe cases, the distal vasculature becomes maximally vasodilated. And in a paradoxical reduction of blood flow occurs. That's a Steele phenomenon. So blood then is routed to healthy tissue in response to the vasodilatory challenge. So the blood flow decreases where it really should be increasing ideally, but that just means that it's already maximally compensated and can no longer dilate any further. So there are options for vasodilation challenges. You can do inhaled carbon dioxide. You can do breath holding techniques as well. Both of them can work. We preferred to use IV Diamox, acetazolamide. This is because it is really well suited for timed acquisitions. And so we would give our Diamox, and then we could get the imaging and have a good sense of what our time frame was for the medication to work and for the images to be acquired. So this is what that workflow looks like for us. So you get your baseline flow measurements, then you administer the IV Diamox over 5 minutes. Then you wait for 10 minutes to achieve that vasodilation, and then you repeat the flow measurements. And increases in the flow are around 40% are what are expected. That would be a normal response. However, if that is not present, if that is reduced or absent, or even if you have Steele, that is impaired or a loss of hemodynamic reserve. So this is an example of a flow map from the NOVA study that you might get from one of these types of protocols. And what you have here is an image of not only the circle of Willis, but you get all of these numbers associated with each of the main arteries, as well as a direction of flow. And so in black, these numbers represent the pre-Diamox flow in an artery. In blue is going to be the post-Diamox flow in the artery. Then underneath is going to be the percent change after the administration of Diamox. And then the arrow indicates the direction of flow. And so in this as an example, this is a relatively normal response, although perhaps a little bit more than expected increase in flow, but you do see an increase in flow in this particular artery. Whereas here in the right MCA, you see impaired hemodynamic reserve, that there's not much of a response at all to the Diamox. And then in this particular artery, you see that the flow goes down. That is possible Steele happening in that particular artery. So this imaging is then coupled with functional MRI. So this is where we can get the regional responses. So we do functional MRI because it uses blood oxygenation level dependence, a bold contrast that helps to visualize hemodynamic response of increased regional neuronal activity. So this loss of response on functional MRI to the different regions that you're testing can be interpreted as a loss of hemodynamic reserve. So hypercapnia also elicits this vasodilatory response in a normal cerebral cortex that also results in positive bold contrast. So this is similarly, the loss of this response reflects a compromised hemodynamic reserve. So I'm going to go through an example just so you can see this. So this is a picture of the time of flight. So this is prior to an STA-MCA bypass. The time of flight MRA shows an occlusion. So I have this arrow on the screen that shows the right ICA, supraclinoid, has a loss of A1 bilaterally and also the right M1. The distal right MCA branches are present, but they have reduced flow enhancement consistent with collateral flow. And then the vascular territory of the posterior circulation, so the right PCA, is expanded in this particular example, and that's consistent with additional collateral flow in that area. So this is an example after the bypass. So same patient, but this now is a NOVA scan that's done after the bypass. And so the time of flight MRA at 4 days afterward shows flow enhancement through the right STA MCA bypass. That's where I have my arrows. The ACA and MCA, again, still show no flow enhancement, which that makes sense. That would not have changed. And then this is what we see on the bold imaging that we get from the functional MRI. So this panel A is a single axial plane of a global bold. So what we see here is that the map shows decreased bold activation in the right side, which is making sense with all the pictures that I've presented to you, that would be impaired. On B, this just shows the matrix of all of that. So it shows all of the axial slices. And then on C, this is the task-based. This is the functional component of this. So the task-based bold activation. And what's interesting is that for our protocol, we would do one and two trials, and then we map the overlap just as a control. And so what you see is that there's intact activation on the left side in the sensory motor cortex, but you do not see that activation on that right side. So again, that's absent or it's reduced on the right side. Again, consistent with impaired or a loss of hemodynamic reserve. Now, this is on our follow-up scan. So this is the follow-up picture 16 months after. And so it shows an improvement. We see that on the global bold picture that the territory that is blue is less. We see that on the matrix here on the B panel. And then on C, this is the most interesting one. This is where the task-based bold activation shows that we're starting to get that activation back on the right side. So that is all with what we do with the MRA imaging, and that is how we're able to assess preoperatively and postoperatively and across time with these patients and how they respond. But we also have measures that were developed at UIC for doing intraoperative measures, and these are very important for helping us predict which patients will have long-term success in their bypass or not. So it's important to highlight that there are different ways that the literature will describe a vessel having patency and good flow, which are not necessarily true. And what I mean by that is having an artery that is patent on angiogram or patent on ICG during the surgery, that's a binary that tells you that it's open, but it does not tell you that it's good flow. It does not tell you that it is adequate flow. Just having a good vessel diameter does not necessarily tell you that it's good flow. The velocity also, this is a trick because a stenotic vessel may have increased velocity, so you have to be careful with how you interpret that. And then a pulse. If you're able to palpate a pulse on a vessel or see a pulse on a vessel, that actually does not mean that it's open or has good flow either. That an occluded vessel, like a stump of a vessel, might still have a pulsation. So this is important to note that these things don't necessarily indicate that you have good flow through the bypass. So these are some of the terms that were really discussed and brought to the literature at UIC, but cut flow and cut flow index. And I'll define both of these, but it's important to show that this probe, this is Dr. Charbel's microflow probe with transonic, helps us to measure these in surgery. And so ultimately, to get back to this, cut flow is going to be the measure through the artery once you have the STA, the donor artery, once you have cut it and prepared it for bypass, and you want to see what it is able to give you. The cut flow index is more of a ratio, and I get to those specifically on the next couple of slides. But this flow probe, to explain how it works, it uses transit time ultrasonic technology to measure blood flow. So it quantifies blood flow, and also it gives you this waveform data as well as acoustic feedback, so you can hear it in the operating room. And so you get a sense of, based off of the waveform and the acoustics, what the quality of the data capture and the quality of the blood flow is. But you also get the numerical value too. And so you get a sense of exactly how much flow, as well as the directionality, where it's going. And it comes in multiple different sizes, so you can actually find the right size for your particular bypass and get the most accurate measurement. So when you're ready to measure the blood flow, you do place it around the vessel and then irrigate, and then you can actually acquire these this bit of data. So back to what I was talking about with cut flow. All right, so cut flow is the maximum carrying capacity of blood flow through an artery, the in situ graft. So this is going to be your STA or your occipital artery, for instance, depending on your type of bypass. And once the donor vessel is harvested and you prepare it for the bypass, you use the flow probe to determine the amount of flow that can be carried through the vessel in the absence of distal resistance. So again, you're getting a sense of what this artery can give you without any other strings attached, without it being connected to the scalp vasculature. And so you want to know just what that tube can give you. And so when the STA or occipital artery remains in continuity within the scalp, the flow is usually very low. It's about 5 to 10 cc's per minute. And that just gives you a sense of the distal resistance of the blood vessels. But in contrast, once you've dissected these vessels free and you've cut the end sharply and you've measured the blood flow with the flow probe, that flow increases sharply to about 60 cc's per minute, sometimes higher, sometimes a little lower, but about 60 is what it usually can give you in the STA. And this video is going to give you just an example of how we measure this. I'll show it as an example, but this is the flow probe and how we would measure it. This example here shows us doing the cut flow measurement. So the STA has been harvested, we have the flow probe around it, we've measured the flow, and now we're re-preparing it for the bypass there, where we inject saline. Okay. Now, why does this matter? Why would you need to know the cut flow? It's because it tells you if this is an adequate bypass for you. The cut flow should fall within 20% of what you've measured in the recipient. And because if it's not, especially for a flow replacement bypass, then you need to consider different options available. But that 20% margin is what is protective against ischemia. So this little table here shows that the flow, as I mentioned, for an STA is quite good. It's about 60 cc's per minute. And as opposed to like a vein graft, that'd be about 80 to 100 cc's per minute to give you a sense of that reference range. Now, the other term I mentioned, the cut flow index, this is a ratio. So this is going to be, your cut flow is the bottom, whereas the bypass flow is measured right after you've completed the bypass. And this will give you a sense of how well this bypass will do over time, because the cut flow index of about 0.5 or higher, that tells you that that's most likely going to remain patent over time. But anything less than that tells you that it's probably not going to remain patent, or that it's almost a 50-50 chance of whether it's going to remain patent or not. So these are some of the primary studies that looked at this. So the cut flow index was found initially back in 2005 when this first study was done. Cut flow index of 0.5 or higher is a significant predictor of patency. It's about 92% of patients with these values remained patent, whereas less than that, it was about 50%. So again, about 50-50 chance. If it's lower than that cutoff threshold, then there's a chance that it may fail. The follow-up study that was done in 2019 was consistent with these results. And that 0.5 value did show that about 83% of patients had a patent bypass. But then again, if it was less than 0.5, 46% remained patent. And the one last thing on this slide that I wanted to share is that we've done several studies that look at bypass flow over time, but this one in moyamoya disease specifically, the bypass flow is expected to decrease over time, but that is in concert with the development of collaterals. And so over time, we do see that in moyamoya disease. So the last couple of slides specifically on bypasses, this was a question of my fellowship, and this was a question of the research that I performed, is why do bypasses fail? And so first off, to go back to overall flow equations, this flow is a function, and you're probably very familiar with this equation. Flow is a function of a pressure gradient, radius to the fourth power, length, and viscosity. So it's not only a question of conduit size, and that is a misunderstanding in a lot of literature that was done before now, where a lot of emphasis is placed on the radius of the vessel, which is true. It is a very important factor. However, if there's no pressure gradient, there is no flow, and so that the pressure gradient, especially in the mind of Dr. Charbel, is essentially the most important thing to take into mind. So this rationale explains why the STA, which is a relatively small vessel, can work as a suitable conduit in many bypasses. And also why the cut flow index can predict patency so well, because it's a question of supply and demand. So this was a paper that we published last year, but this is a question of, does disease etiology matter for the long-term success of bypass patency? And so specifically, we were looking at this question of moya-moya disease again versus intracranial atherosclerotic disease. And at the last follow-up, the rates of occlusion actually did not really differ between the two groups. So last follow-up, over a course of a couple of years, in the patients that had that follow-up, 25% or so was occluded in both groups. And so it was very similar. But of the occluded bypasses, the atherosclerotic disease group had more failures within 1 week compared to the moya-moya group. Okay, and 25% of the atherosclerotic disease versus 6% of the moya-moya disease had occluded bypasses that were symptomatic with stroke or TIA. And the patients with atherosclerotic disease had a higher rate of stroke at last follow-up, which all of these make sense intuitively. But the cut flow index remained the best predictor in the study of occlusion. And so again, speaking to how well this is a predictor of the long-term success of bypasses. Now, this was a paper that we just published this year, actually, but this was something that I was researching over the past year or so. And are there any specific risk factors that point to whether a bypass may occlude? And the thought was that any kind of cardiovascular risk factors, so anything that might cause vessel disease, might put you at risk for occlusion. And so we looked at this. So in patients that had patent bypasses versus not patent, we wanted to look at specifically these comorbidities or any kind of racial or ethnic differences to see if there were risk factors between them. And you can see in this table, actually, there weren't. Really, the comorbidities, hypertension, hyperlipidemia, diabetes, they really did not differ between the patients that had patent versus not patent bypasses. But what we did find was going to be this difference in male versus female, and I'll get to that in the next slide. We also looked at these flow measurements. So in flow measurements between patent and not patent, the only thing that came out was the cut flow index as a predictor of difference between them. So no relationship, in summary, between our typical cardiovascular risk factors to bypass patency, at least in our data. But patient sex and the cut flow index were related. So then we took a step further and we looked at men versus women to see if there were any specific differences here. And what we found was that despite men having a higher rate of comorbidities like high cholesterol, diabetes, as well as tobacco use, and just overall the total of comorbidities was higher in men compared to women, women still had a higher chance of bypass occlusion compared to men. And what we see here is just an example, because remember, cut flow index was another significant predictor of bypass failure versus patency. And so this was a two-way ANOVA that wanted to separate out cuff flow index with patient sex and bypass patency. And there was no difference between men and women. There was a difference between cuff flow index on patent versus not patent bypass, but no real difference between men and women for that specific measure. So what that speaks to is that patient sex in and of itself is an independent predictor, at least in our study, of patency. And so our propensity score matched analysis that controlled for cardiovascular risk factors found that female sex was 3.17 higher odds of occlusion than when with men. And this effect did remain independent after we added the cuff flow index and adjusted for it. But cuff flow index also was an independent predictor too. All right, I have a couple more slides, some final thoughts. Like I said, the whole presentation was going to be about bypasses mostly, but here are some other diseases that we've looked at before. This is not a comprehensive list, but just want to make you familiar with some of the things that we've looked at and how this type of imaging can be useful. So carotid dissections, vertebral artery dissections, we did look at this at our institution also. This is something that I had studied earlier in my fellowships. And we looked at how blood flow changed over time, the natural history of dissections in these patients. And in general, flow improved in patients over time. So even if patients had low flow, eventually over time, they got a little bit better. But there was a stratification. So those with low flow still remained in the low flow group, but they improved. And those with higher flow did still improve, but they still were stratified in that way. And importantly, this cutoff of about 63% vessel narrowing was predictive of having a presentation with stroke, which that makes sense with our carotid data and other studies, that having this 63% or so of narrowing of the vessel predicts the presence of ischemia. Intracranial atherosclerotic disease. This is something that Dr. Hinjani really championed specifically for the posterior circulation. The Veritas studies looked at this. And so they looked at vertebrobasilar disease and found that a low flow state was an independent predictor of recurrent stroke. And so there's a lot of literature, as I have shown here, that she really brought to the forefront on vertebrobasilar disease and using this technique, using quantitative MRA with NOVA. AVM assessment, I will not go into detail on this. There's a webinar that I did last week with your group that talked about this extensively, but we have a lot of studies from our institution that looked at AVM blood flow, how it changes with different embolization, how we can use it to assess AVMs, how we can use it to look for high-risk features, including draining vein stenosis, feeder vessel aneurysms, the presence of microhemorrhages. These have all been looked at our institution, and we've used this to help guide our flow reduction strategies preoperatively as well, and then also looked at them for stereotactic radiosurgery and the response to it. So it can be very useful for that as well. So in summary, understanding cerebral blood flow is critical to the practice of vascular neurosurgery. And quantitative MRA provides a non-invasive means to measure cerebral blood flow. It helps you gain insights into these pathologies and then monitor response over time to the treatments that we do. And again, thank you to the Asian Congress of Neurological Surgeons for inviting me today to share all of this research. And then thank you, of course, to my mentors again for letting me be part of this tradition of flow-based management of cerebrovascular diseases.
Thank you for excellent review of flow-assisted surgery technique, mainly in bypass surgery. So can we have comments now, or there will be questions, or how to manage?
You please go ahead and give your expert comments. Prof.
Yeah. From the beginning, I like to start from the back of your talk. You mentioned Veritas study, and it describes a group of patients in a high risk of stroke, and there is still any randomized study on revascularization of these patients. And on the other hand, we have 3 big randomized strong studies in carotid artery territory, and none of them proved clear benefit of revascularization surgery. So for me, it was interesting to hear mentions about CMOS, maybe slight discussion on CMOS results is now beginning, and we also believe on bypass in these indications, and we are pushed closer to the stroke origin in these cases. One question regarding pediatric moya is raised. What's your opinion on revascularization, on direct and indirect brain revascularization on pediatric moya?
Sure. Yeah. Pediatric revascularization is definitely challenging because of the vessel size. And so that, direct bypass is sometimes possible. But I know in our experience at University of Illinois, when I was a trainee, we mostly did indirect bypasses for these patients, but occasionally if we could get a suitable STA and perform a direct bypass, we would. But that's the challenge, is just having a vessel that is big enough to even perform the surgery on.
Yeah, another big topic of this kind of revascularization is cognitive outcome, and we should mention that this topic is also unclear and very difficult to let's say establish and to evaluate. I enjoyed your talk on CO2 reactivity or hemodynamic reserve testing. I think we should keep in mind that there is no clear study proving that this situation is connected with higher stroke risk. On the other hand, it's very good. It's very good example of situation where bypass sometimes works. I think there is some group of patients where bypass might work, but we still are not with our techniques are not fully competent to find this maybe small group of patients than bigger studies are using. What do you think about this?
So this is something that since I left UIC, I'm still working here and there with them on a topic very similar to that, because we wanted to know there were a good many patients that we just followed over time with that hemodynamic reserve protocol, because they had maybe an occluded artery, but they had good hemodynamic reserve, or it was okay. And so in those patients that were not clinically symptomatic yet and had okay or preserved hemodynamic reserve, then we would follow them over time. And so we're actually going back in the data at UIC to look at which of these patients that we were monitoring actually converted to needing a bypass or became clinically symptomatic, and which one of them we just continued to follow. And so that is a question that we're interested in as well, because I agree, it has not really been looked at in this particular method. While we feel like it makes sense logically, it has not been fully validated in that way. So I agree.
Yeah. We also use flow quantification using MR, and sometimes we have big problem with mainly in polysclerotic patients with arrhythmia, yeah, because this is big limit of these techniques. But we don't have experience with bolt techniques. Is bolt technique somehow influence of this heart instability of the patient as well, or is it completely without any artifacts from this?
There can be artifacts on bolt. There can be artifacts, especially if the patient has had a big stroke in the past. And so you have to take that into consideration, whether, because if they've had a significant stroke in the past, they're not going to activate that part of the brain. And so you do have to be mindful of that and not read that into what the bold reactivity is. And so you have to just be mindful of what parts of the brain are structurally not intact anymore because of a prior stroke. And so bold, yeah, it does have that. But we like bold otherwise because of the reason that I mentioned, that it's used in functional MRI, and we can take advantage of that for that regional assessment to see what parts of the brain are or are not activating. And so that does give you a sense of what parts of the brain are that have impaired reserve or not. So it gives you a little more granularity into the locations of the brain that might be affected. But there is an artifact component that you have to be careful with.
And last two comments is how do you explain higher percentage of bypass failures in atherosclerotic disease versus moya? Do you think that atherosclerosis of STA plays role, or should we think about flow augmentation of STA before the bypass?
So that's a good question. That's what really led me to do the second study about the risk factors, because we initially, when we saw that, because the first study we did was looking at moya disease versus atherosclerotic disease, and we then thought to ourselves, especially because we review these patients every week in our neurovascular conference, we thought that maybe it's actually the STA. Maybe the STA has disease in it, just because that's the nature of atherosclerotic disease. Maybe there's a problem with the donor vessel. But then when we looked at different risk factors, the cardiovascular risk factors like high blood pressure, diabetes, and tobacco use, and looked at it patent versus not patent, that actually didn't pan out like we thought it would. So that was a little bit of a head scratcher that we weren't sure about. We had talked about maybe at some point in the future looking at, like, just, when you clean up the STA as part of the process to get it ready as the bypass, usually you trim off part of the end of it. And so we thought about sending that off to pathology to see if there's something on a microscopic level that could account for it. We don't have, that was not a study that we ended up doing, but it's something that could be done to see if there's something on a microscopic level that's going on. But that is, I agree. I mean, that's still a question mark of why the patients with atherosclerotic disease fail. And we were a bit surprised with our results for the second study when we were trying to figure out what risk factors really played into it. So I think it's a little bit of a mystery still, not clearly answered yet, but there's more room for research on this.
Yeah, thank you. And I finish my comments with last question. What's your indication for bypass in dissection, clearly? So there is many treatment options in carotid artery dissections. How do you stratify your treatment in this indication?
Yeah, so I use this protocol. I've brought the protocol over to University of Wisconsin where I am, and so we're building this protocol currently and using it now on our patients, because I do think that the logic behind doing hemodynamic reserve imaging makes sense. And so for patients that have an artery that is occluded, and they show that they have maybe scattered watershed infarcts in that territory. So it is symptomatic. So even if maybe clinically they're not showing, but they are showing on their imaging that they have symptoms. and they have impaired reserve on that side. They've already been medically managed. That is a patient that is, I think, that is the only option available to them. They've already been medically managed. They're still having strokes. They have an occluded vessel, and they have no reserve. So that is a patient that would benefit, in my mind, or has the potential to benefit from a bypass. Anything that doesn't meet all of that criteria, any patient that doesn't meet all of that criteria, then it's still a gray zone. And to me, it's a conversation with the patient about the possible benefit, but also the risks of the surgery. And we're not sure if it'll benefit or not. So you do have to, if they don't meet all of that criteria, then you could potentially move forward with a bypass if they have significant disease, they have the occluded vessel, they have maybe some watershed strokes, but they're not clinically symptomatic from it, but maybe they have good collateral. So that doesn't meet all of the criteria, but you could make the argument that they could potentially benefit from a bypass. So I think it's those three things mainly, is that you got to have an occluded vessel, impaired hemodynamic reserve, and some form of symptoms, either clinically or on radiographically with strokes.
Yeah. Thank you for your talk and for your answers. Thank you very much.
Oh, thank you. And one quick thing I'll mention for your first comment that I didn't get to address regarding posterior circulation bypasses, you're absolutely right. That's something that has been not studied well at all. And it's something that even though the Veritas study that Dr. Hinjani did, that was looking at patients that did not have bypass. And so that would be an area of research that should be done in the future, but that, to my knowledge, has not been done yet.
As well as for endovascular treatment of this group of patients.
Oh, absolutely.
As well as endovascular.
Yeah.
Mm-hmm. Yeah.
Thank you very much. We have a wonderful discussion going on, and Prof. Zona has raised his hand. Would you like to add something?
Yeah. Do you hear me?
Yeah.
Yes.
Yes. I have a question for Dr. McGuire. Thank you very much for your presentation. I met Fadi Cherbel many times here in Italy and in Helsinki and whatever in the world. And I have two provocative questions for you. The cost of probes could be quite expensive, especially here in Europe or in low-income countries. And they are not always so easy to put, especially in deeper surgical fields, especially in the surgical areas. So if you should choose in which kind of surgery or bypass surgery you will reserve these probes, if you have to choose?
Good question. So obviously it's going to be any form of direct bypass, but specifically to measure the most usefulness is probably going to be assessing for flow replacement bypasses, because that's going to tell you if you have enough flow to accommodate the artery that you're occluding, like intentionally occluding for an aneurysm or a tumor. And that would be the most high risk from a perspective of you are taking away an artery in order to treat whatever disease you are treating. And so you need to know if you're giving enough blood flow back to the artery you have taken away. That would probably be the most important one, because it is definitely useful for bypass surgery, as I talked about, for flow augmentation, but it's not as critical as a question as flow replacement bypass. So if you had to choose, I would say the flow replacement is going to be the more important one, because it will change what type of graft you're going to use for that.
Thank you very much.
Maybe I will add to this topic one idea. There's no transit time flow measurement gives us the information about the flow volume. It's clear, but there is another stuff which sonography can create, and it's sonolysis, which is destruction of thrombi, and also its activation of fibrinolysis distal or behind the artery which is insonated. And our group published recently in the BMJ, British Medical Journal, paper on sonolysis in endarterectomy. And I think we should in the future evaluate the effect of sonolysis of donor of the artery to distal vasculature. So not only that we are getting the information, but we also, let's say, somehow activate distal fibrinolysis, and it's now proved by our paper. Yeah. So,
Thank you.
Are there any questions to this?
Yes, we can invite comments, Dr. Liu or Ben.
Yeah, I have two short questions, Professor. I do agree with you. The pressure gradient play important role in the success of the bypasses. What is your opinion regarding flow direction? Because if you put a M4 bypass, you have more forward, also a reverse flow compared to M3 bypass, where you have more. Because the reverse flow, we have more turbulence, and the effective flow may not be good enough for the brain perfusion. Do you think that this also play a role in the success of the bypass? My second question regarding cut flow index. And many studies have shown that the STA did dilate after some time in the successful bypass. And I do believe this also indicates that there's a change in the number of cut flow index. Do you think this cut flow index is a fixed figure or also a dynamic figures? And would you think that now which one is playing more important role, the cut flow index or the pressure gradient? Do you have any experience with a very high cut flow index but low pressure gradient? The bypass is still successful. Thank you.
Sure. Yeah. So for the first question regarding M3 versus M4, we did not specifically look at that, but we routinely did M4 bypasses for this indication. And so I can't really speak to it with any direct data on it, but just our practice was to do M4 bypasses. But I think that you make a good point. Ultimately, if you are giving good blood flow to that area, which is the end vessel, right? So it's really close to where it's going to be becoming the arterioles and capillaries, then it probably doesn't make that much of a difference for the direction of flow versus other vessels that it might, where if you're actually way more proximal, the directionality of the flow does make I think a bit more of a difference. But that is just me thinking it through. I don't have data for that. But regarding your second question, for the cut flow index, it definitely is a dynamic number. You only can measure it really once, though. And so there's not really a way to measure the cut flow index again after surgery. But theoretically, it is a dynamic number because, and we see that in surgery too. So if we were to measure the bypass flow in surgery, and we measure the bypass flow at different blood pressures, at different sedation levels, it does change a bit. And so you have to keep that in mind. So it is a dynamic number, how much flow is going to get to the vascular bed in the brain. And then we've seen that too, where on follow-up imaging, especially if it's a good bypass, and especially if it was a good indication that the patient really needed the bypass, that the artery can become slightly dilated over time. And so we have seen it. We've also seen the artery regress too over time in patients that maybe develop really good indirect collaterals over time. So we've seen both. And so it is dynamic. So I agree. And then regarding whether the pressure gradient versus cut flow index is more important, it really is speaking the same language. The pressure gradient is saying whether there is demand. And so if there is a gradient that exists, that means you have demand that is needed for the blood flow. So it's a way to measure the same thing. And so even though it's technically not a measurement of pressure, the cut flow index is not a measurement of pressure, they are speaking to the same quality of whether there is demand in the vascular territory that you're looking at. So I don't know that one's more important than the other. I think they're actually kind of the same in a way.
Thank you.
Yeah, thank you, Laura, for your quick presentation. So I have one comment and also one question. The comment is, first, you mentioned about the CMOS study. So there's, just to remind the audience, there's also another CMOS follow-up study showing the potential role of the bypass in the for those.
Can't hear you, Ben.
Yeah, am I audible? Yeah, so there is a CMOS follow-up study showing the potential
Go ahead.
of the bypass for the steno-occlusive MCA and also the carotid stenosis. And then because the initial CMOS bypass, so I've just been to the subtotal course. The comment from the technical is that you can observe that the temporary clamp time is 48 minutes, if I'm correct, for those patients with the stroke, and 50-something minutes for those suffering the stroke. So the occlusion time would be relatively long, according to some expert opinion. So this might not complicate the result, and we need to interpret the study carefully. My second question is about those. What is your opinion towards the still phenomenon? Because I sometimes observe that sometimes we perform the Diamond challenge test clinically. So maybe the report coming back, there have sufficient reserve, but there's still phenomenon for the patients after the Diamond challenge. So would that be an indication for bypass for the still phenomenon? Yeah, that's what I want to know. Thank you so much.
Sure. Yeah. Thank you for those comments. So, regarding the CMOS study and what you mentioned, it definitely can confound how you interpret the results if the clamp time is really, really long. That being said, I mean, these bypasses are very distal, and you are isolating usually just one small branch. And so, yes, that long clamp times for that surgery may not be clinically relevant, even if they may have a small hit in that area, if you were to do an MRI. So I agree, though, you have to be careful with the interpretation of those results for that reason. Regarding the steal phenomenon, so yes, that would be an indicator of a lack of hemodynamic reserve, because that means that area where the steal is happening in the brain already is maximally dilated. They are fully dilated. There is no way for that vascular territory to get any bigger to accommodate and get more blood flow. And then once the normal part of the brain gets dilated, then that steal happens. So that is a true measure of hemodynamic reserve impairment and a problem. But in terms of whether to do bypass or not, specifically in atherosclerotic patients, I kind of go back to the 3 criteria that I mentioned about whether to do bypass on these patients or not, because they may have a steal phenomenon, but if they're not actually symptomatic from it, either clinically or on the MRI showing small strokes, then it's hard to make the case that it is relevant. So even if steal happens, you don't know if it's a relevant question, and especially in a situation where it is very much a gray zone whether we do bypass on atherosclerotic patients or not. I don't think that just having the steal phenomenon by itself is enough of a criteria to move forward with a bypass unless they have everything else that's been met too. It would be a conversation with the patient to talk about the potential for bypass and maybe the benefit, but I don't think it by itself is enough.
Yes, thank you so much. It's very difficult questions for these ischemic cases. Thank you so much.
Thank you. If there are any further questions, if no, I'll ask just one technical questions about your technique of bypass. When you harvest the STA, do you take it along with the cuff of Gallia or bear it along the path? Because this question has been asked so many times in the past for any bypass surgeons, but the chances of vasospasm between when you take it, bear it out, and whether you take it with the cuff of Gallia. What is your technique and what results have you found?
So there's a cuff of just the soft tissue around it when we take it, but then because vasospasm can happen. So as part of the preparation, we would take the STA with a little cuff of soft tissue around it, but not galea, but just soft tissue and adventitia. And so there, once we have isolated the STA, then we wrap it with like either a telfa or a large cottonoid patty that has been soaked in papaverine. And so we just put a little blanket around the STA while we do the rest of the opening of the surgery. So we open the temporalis muscle, we open the bone, and do our craniotomy. And so it is being treated medically with a papaverine to help dilate it, because during that process of dissecting it, having it exposed to the heat of the microscope can definitely cause injury, but also vasospasm to the artery. So you have to be careful about that. But we don't do anything more than just that small cuff of tissue around the STA. But by doing this papaverine-soaked patty, and there are other medications you can use instead, but that's what we did. That seems to help prevent the spasm.
Thank you very much. We can have the final remarks from Prof. Jerry Fiedler.
I'd like to thank ACNS and Dr. Laura McGuire for opportunity to discuss this topic once again, because it's difficult to continue in this topic under the power of big studies which are nowadays available. Thank you all, and see you next time.
Well, thank you very much. It was indeed very informative. So I'll close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I'd like to thank both speakers of today, Prof. Gianluigi Gisona and Dr. Laura Stone Maguire, as well as the chairs, Prof. Paiva and Prof. Jerry Fiedler, for the time and support for the ACNS webinars. Very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have around 1,130 people who have logged in through all the different channels. Also, special thanks to my co-hosts who joined in, Dr. Liu Bun Singh from Malaysia, Dr. Ben from Hong Kong, and Dr. Hui Pham from Vietnam. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.